Good morning, everybody. So we are going to get started today with understanding the HGN test with Dr. Karl Citek. Just a quick introduction real quick. Dr. Citek is a professor of optometry at the Pacific University College of Optometry in Forest Grove, Oregon. He has been involved in teaching eye science at the DRE schools in Oregon, Washington, and Montana, also observing alcohol workshops, certification sessions, and several ride-alongs around the country. He has also testified as an expert witness for the prosecution on the admissibility of HGN and DRE evidence at numerous hearings and trials around the U.S. He has pre-recorded the video for today's session, but he is also here live with us. We do ask and remind you to, if you have a question, go ahead and use the Q&A at the top right of your screen instead of the chat. We will be monitoring the chat as well, but to make sure that any of your questions do not get lost, go ahead and put them in the Q&A, and we will have about 15 minutes at the end of this presentation to go ahead and have Dr. Citek go through with all of those questions for you. So without further ado, we're going to go ahead and get started with this video.
Thank you for the kind introduction, and thank you for inviting me to speak with you today about the horizontal gaze nystagmus test. Before we do so, let's remind ourselves what the purpose is of field sobriety tests in general. These are screening tests that are usually conducted at roadside, and they allow an officer who has reasonable suspicion of impairment to establish probable cause for arrest. Secondarily, in refusal cases and other situations, such as drug recognition expert evaluations, they allow an officer to describe the presence of impairment. Keep in mind that field sobriety tests, including the HGN test, are not performed at random nor in a vacuum. An officer must have reasonable suspicion for requesting the test. They will not do so randomly or on a driver whom they do not suspect of being impaired. They do correlate to physical impairment, such as that caused by intoxication, but they do not correlate to driving impairment, simply because driving scenarios are so different from one situation to the next that we cannot accurately predict exactly what will happen, if something will even happen, with a particular level of impairment. Nonetheless, eye movements are critical for driving. We don't just stare at the imaginary spot directly in front of us down the road. We scan our eyes from side to side, looking at street signs, looking at lane markings, looking at other vehicles, and occasionally we look in our mirrors and elsewhere. We'll be exploring some of these things with some of the demos that we'll be doing as part of this presentation. Keep in mind that intoxication causes changes to the central nervous system, primarily to the functioning of the brainstem and the cerebellum. These are the parts of the central nervous system that control our eye movements, among other things. Very often we don't know the exact mechanism by which intoxication nor other impairments cause a particular change in function, but we're pretty certain from animal models and from the work that we have done that we know what is going on, that this is where the changes occur. And they do so pretty much consistently from one person to the next. Yes, of course, there are always going to be exceptions, but for the most part, human beings are going to behave in a particular fashion when presented with a particular stimulus, such as intoxication. Prior to the start of any testing, an officer is going to ask certain health questions. Is the suspect wearing glasses or contact lenses? Is the individual blind in one eye, perhaps? Or does he or she have other eye problems or vision problems? Perhaps two of the most common that may occur are strabismus and amblyopia. Strabismus is an unintended eye turn, when an eye is turned in when it should not be, or out, or perhaps up or down. And this should be readily evident to the officer during the pre-test checks, which we will discuss shortly. Amblyopia is a condition of reduced vision without any obvious physical injury or damage, and it usually happens in one eye, and it typically occurs because of an uncorrected strabismus or uncorrected need for eyeglasses early in life. Nonetheless, either these conditions will be identified during the officer's pre-test checks, or they will have no influence on the conduct of the test itself. Alternately, could the individual have had any eye or head injuries, So the officer is going to screen for that. And are there any medical or physical problems, such as the individual suffering from a stroke or hypoglycemia, low blood sugar, insulin shock, and diabetes, or heart attack, or is there a vestibular system problem, or other balance problems, or other physical problems? These are typically questions that an officer will ask prior to the start of any test. Conducting the test itself can be done in different postures. A study that we published in 2003 demonstrated that testing a suspect in a seated posture or even a lying down posture is equivalent to testing in a standing posture. So that certainly is acceptable. One excuse that often has been raised by the defense is that the suspect was sleep deprived, was awake for at least 24 hours continuously at the time that the test was conducted. The study that we published in 2011 demonstrates that sleep deprivation, being awake for at least 24 hours, has no effect on field sobriety tests, including the HGN test. So sleep deprivation at that amount, 24 hours or so, does not induce nystagmus, nor any other changes in field sobriety tests that would be confused for intoxication. Weather can also be a factor. And of course, here we can consider one of the field validation studies that was conducted in the 1990s in Colorado, in which they did their testing in the wintertime when it was cold and even snowing lightly. And of course, that had no effect on the conduct of the field sobriety tests at all. Prior to the start of the test, as I mentioned, after checking questions, asking questions of the suspect, the officer is going to conduct certain pre-test checks. One is to check for equal pupil sizes. Recognize that a fair number of individuals, about 1/3 of any normal population, have a difference in pupil size of about 0.5 millimeter or so. But yet that prevalence decreases to about 10% or less if the difference is 1 millimeter or greater. Where an officer needs to be careful, needs to be mindful of this, is that if an individual has a recent onset of a sudden difference in pupil size and has no knowledge that this exists, that could indicate that there was a recent head injury or a stroke. So, of course, either of those would be an emergency medical situation. An officer is taught to recognize that. The other pre-test check that is conducted is for equal tracking. And here the officer asks, do the eyes move together? Does each eye have full range of motion? And is resting nystagmus present? Now, resting nystagmus will typically occur with conditions such as congenital nystagmus. And here in this video, we can see a young lady who has congenital nystagmus. Congenital simply means that a condition is present from birth or develops shortly after birth. There's no obvious or known medical cause to it, but obviously there is, but we don't know exactly what it is. Nonetheless, nystagmus is present all the time. And as we can see for her, that nystagmus is present even when she's looking straight up. And this, of course, would not be a positive finding on the vertical gaze nystagmus test, because even though nystagmus is present, it's going in the wrong direction. As we'll see, for VGN, we expect the eyes to be bouncing up and down, if that were a positive finding, not side to side. So let's consider the test itself. There is no such single creature, single entity known as horizontal gaze nystagmus. When we use that term, when we use that phrase, we're referring to a 3-component test. Those 3 components or subtests are, in order, lack of smooth pursuit, distinct and sustained nystagmus at maximum deviation, and onset of nystagmus prior to 45 degrees. The test is conducted in this order because this is the order in which we expect the clues to appear, the indicators, specific indicators to appear with increasing levels of intoxication. We know this for certainty with alcohol intoxication. We can presume it to be the case with other drugs that can cause these changes in eye movements, but we can't test carefully enough, as carefully as we can for alcohol, for other drugs. Now let's look at each of the subtests individually. Smooth pursuit is the ability to track a target with the eyes when there's relative movement between the observer and the target. Either one could be stationary with the other moving, or both could be moving, but perhaps at different speeds or in different directions. Under the test conditions that are used within the HGN test, that is, using a large target, moving over a large part of one's visual field, and moving in a very predictable manner, the maximum speed of smooth pursuit that we would expect is about 120 degrees per second. That would be the equivalent of something moving across your visual field in the time of about 1 second if you were to keep your head perfectly still and just try to follow with your eyes only. That's pretty fast. And we do know that most normal individuals can track at speeds of at least 30 degrees per second. And that's going to be important for us because that is how the test is conducted. When the officer moves the stimulus from one side to the other, he's going to cover about 60 degrees of eye movements in about 2 seconds. So that's about 30 degrees per second. When moving from one side all the way to the other, he's going to cover about 120 degrees in about 4 seconds, or again, about 30 degrees per second. Now, let's look at the importance of smooth pursuits, or lack of them, if they exist, with a couple of demos. What I'd like you to do is just look at the little spot down the road indicated by the star. Move yourself back from the screen so that the distance from the top of the screen to that star is about the width of your hand. So move back if you need to, or move closer if you need to, so that you have about that width present. You're going to see little Johnny on the side of the road. He's right over there on the side of the road. And he is going to kick a ball across the road that will pass in front of you and magically come back. The whole time that he does so, I'd like you to keep looking at that little purple star. And just keep looking right there. Are you ready? Here we go. And I'm going to ask you about the balls as they go across. Wasn't so easy, was it? Well, now what I'd like you to do is watch this again, but take in all the information. As soon as you see a ball, follow it with your eyes and see if you can identify the color and the shape that is on the ball. Ready? Here we go. I trust that was a little bit easier the second time around. So of course, we're talking about a lack of smooth pursuit. In the first instance, I ask you not to make smooth pursuit eye movements. So just keeping your eye fixed on the star in front of you. It may have been difficult for you to identify what was going past in your peripheral vision. Now, if someone has natural lack of smooth pursuit, very often they can compensate with head movements or fast eye movements known as saccades. And we'll address those shortly. So in case you were wondering, what were those symbols in reverse order? A blue C, a yellow P, red I, and the really small one at the very beginning, just a little @ sign, a green @ sign. All right, let's come back to our driving scenario. Now what I'd like you to do is look quickly from one location to another. So looking from the speed limit sign, and I'll highlight that each time when I want you to look there, and the little star in the side view mirror, looking back from one to the other and nowhere else. Are you ready? Here we go. Okay, whom did you run over? Was it Mickey? Was it Lance? Was it Pee-wee? Or what, Carl? Are you kidding? I didn't run anybody over. Let's try this again, but now take in all of the information. Not simply looking at the speed limit time, but being aware of it. Not simply looking at the rearview mirror, but being aware of it. Oh, what happened? Yeah, ran right into Pee-wee. Sorry about that. Well, what are we considering here? These are saccades, also known as saccadic eye movements. These are normal, fast scanning movements, typically about 300 degrees per second or faster. So looking all the way from one side of your vision to all the way to the other covers about 120 degrees. If you did that at a speed of 300 degrees per second, it would take you less than half a second, 4/10 to be exact, to move your eyes from one side to the other. That's pretty darn fast. Now, we use saccades all the time for everything that we're doing. When we're reading, walking around, driving, moving our eyes quickly from one location to another. So this is a perfectly normal, perfectly natural eye movement. The only issue for us, though, is that when the saccade occurs, vision is suppressed. We stop processing visual information for that brief instant during that fast eye movement. Regardless of how long it takes, vision is suppressed. Now keep this in mind for when we talk about nystagmus in just a bit. The issue, of course, with lack of smooth pursuit is that if you cannot compensate for it properly, if you're not used to it, if it's not normal for you, and you need to make saccades, you're going to miss seeing details about important objects and their motions. So you will lose information if you have to make a saccade in place of lack of smooth pursuit. And if you can't make saccades, well, that means you must move your head from side to side in order to see things off in your peripheral vision. All right, let's move on then to the second subtest of the HGN test, distinct and sustained nystagmus at maximum deviation. Now, about half to 2/3 of normal individuals have a phenomenon known as endpoint nystagmus. That is, when they deviate their eyes all the way to a maximum lateral extent, they'll exhibit a little bit of nystagmus. The difference, though, between that and distinct and sustained nystagmus at maximum deviation is that endpoint nystagmus usually is small in amplitude, so often it is not distinct, and it usually goes away within 1 to 2 seconds, so it is not sustained. That's the difference there. The third component of the HGN test is checking for what is referred to as onset of nystagmus prior to 45 degrees. In the medical and neurological literature, this is often referred to as gaze nystagmus or gaze-evoked nystagmus. For testing purposes, the officer moves the stimulus at about half the speed at which he or she tests for lack of smooth pursuit. And with practice, through training, the officer can estimate the angle of onset when nystagmus occurs. Again, the big difference here between what an officer expects to see and the neurological condition of gaze-evoked nystagmus is that if this is due to intoxication, it's going to be large enough, easy enough for the officer to see. It will be distinct, and it will correlate to the level of impairment, where neurological gaze-evoked nystagmus usually is of small amplitude that would be impossible to see without some very expensive, very fancy recording instruments. We do know that there is a good correlation between the angle of onset and the level of intoxication. This data originally comes from a paper published in 1976 that showed pretty much a straight line relationship between the blood alcohol concentration and the angle of onset. And as you can see from the data, there's a general downward trend, decrease in the angle of onset with increasing BAC. We can approximate that straight line relationship with what has been referred to as Tharp's formula, or as I like to say, Tharp's approximate formula. The officer can estimate the angle of the blood alcohol concentration from the angle of onset by this formula, 50 minus the angle of onset divided by 100. And this is only a rough estimate. Of course, an officer is not going to be able to testify to this unless asked so by the defense. You're not going to bring this in on direct testimony, but this is the information that the officer uses to see how closely the angle of onset matches to the BAC that is eventually measured. And of course, if the BAC is much lower than estimated by this approximation, then the officer can suspect that there are drugs on board that are causing these eye movement changes. Now, as far as this approximate equation goes, a 45-degree angle of onset, if we did this hypothetical, would correspond to about a 0.05 BAC. That's what the equation would predict. In reality, the average BAC for a 45-degree angle of onset, as demonstrated by this research study and other similar ones, the average BAC at a 45-degree angle of onset is actually about 0.08. So the benefit goes to the suspect in this case. The officer would be underestimating the BAC. The HGN test is scored by one clue for each of the three subtests for each of the two eyes, so a maximum of 6 points. And we do expect the clues to occur pretty much symmetrically, occurring in both eyes. Nonetheless, there are going to be some individuals who at low BACs show an odd number of clues. That certainly is possible. And yes, there are going to be some individuals who at low BACs show 4 or more clues. That is possible. And yes, of course, there are going to be some individuals who at BACs above 0.08 show fewer than 4 clues. And I have seen that personally as well. Yes, that is possible. Again, this is one of the things that makes this test, like the other field sobriety tests, a screening test. It is not definitive proof of intoxication, nor is it definitive proof of any particular BAC or drug level. The other main test, of course, that we're going to consider is the vertical gaze nystagmus, or VGN test. Originally, this was part of the drug recognition expert protocol, and it was added to the standardized field sobriety test in 2002. It is conducted after the HGN test, but it is not part of the HGN test, nor its scoring. It is scored separately. One of the reasons for that is that unlike the HGN clues, VGN does vary with one's experience with alcohol or drugs. Where we say in general that HGN clues do not change based on one's experience with intoxication, VGN does change. And we can consider it to demonstrate a high level of intoxication for the individual. That is when it shows up. So let's look at a couple of videos and a couple of more demos. So this is a video of an individual with normal eye movements prior to the consumption of any alcohol. And we might have seen 1 or 2 bounces at endpoint. Let's see that again. If he has any endpoint nystagmus right there, but you see it's relatively small in amplitude and it goes away rather quickly. It does not sustain for the full 4 seconds of the testing protocol. All right, that pretty much establishes normal. Now, the same individual, a couple of hours later, after consuming some alcohol, as you might notice, has some very different eye movements. So smooth pursuit is absent, and when he tries to sustain his gaze at a maximum lateral position, you'll see the nystagmus that occurs. We have it there. It's very distinct, and of course, it is sustained during the full time of testing, and it is present in both eyes, as we expect. And just retesting. And coming back, looking to the right. And now checking for the onset of nystagmus prior to 45 degrees. And to move the stimulus slowly. And before the eye gets all the way to maximum lateral extent, we can see that little bit of nystagmus there. And as well, looking to the right. And again, finally, the nystagmus does kick in well before getting to the maximum lateral extent, right there. And for vertical gaze nystagmus, when it is present, it would look like this. Keep in mind of what the young lady with congenital nystagmus looked like earlier. Her eyes were bouncing side to side. This is what we expect if intoxication is the cause of vertical gaze nystagmus. Now, time to do a couple more demos with you. So, what I'd like you to do here is you're looking down the side of the road, of course. You notice there's something in your rearview mirror. It's the grill of a big truck right behind you. Now, the road is flat, the road is straight, but you want to look off into the mirror to see what that vehicle is. And when you do so, your eyes start bouncing side to side. You now have nystagmus when you're looking into that mirror. So it's going to make it a little bit more difficult to see what's in that mirror. With your peripheral vision, of course, you just saw that with your peripheral vision, you would not be able to see it clearly. But you try to look into the mirror and you've got nystagmus, either because of distinct and sustained nystagmus at maximum deviation, if the angle is large enough, or onset of nystagmus prior to 45 degrees, if it's a smaller angle. What we're considering here, of course, is acquired nystagmus of recent onset. Acquired nystagmus is well known to reduce your ability to see details. And that, of course, will apply in conditions similar to the test scenarios of distinct and sustained nystagmus and maximum deviation, onset of nystagmus prior to 45 degrees, and vertical gaze nystagmus. It can also happen with some acquired medical or environmental conditions, such as vestibular system problems or following rotation. But usually in those situations, it will have an appearance different than what the officer expects to observe, or it will be done under test conditions different than how an officer does the testing. If it's a vestibular system problem, typically it might involve tipping the head to the side or back, something, of course, the officer does not test for. Or after rotation, the officer does not spin the suspect around. So obviously that's going to be very different. If acquired nystagmus occurs and vision is not suppressed, we have a condition known as oscillopsia. So that's what you noticed when the image in the mirror was bouncing back and forth. And of course, what was that logo? Yep, it was a Ford. Now for this next demo, I'd like you to get up close and personal to your computer screen. Get as close as you'd like. We've got a little speed indicator there, in miles per hour, and a little old-fashioned radio dial going from 88 all the way up to 102. And the task that I'm going to ask you to do is look at the radio dial, watch it, and tell me every time the dial hits 97, tell me what speed you're going. The speed is going to vary between 30 and 50. So it's going to look something like this. When you hit 97, right there, what speed are you going? Oh, about 42, 97, 40s or so. It will be different from one time to the next. So I'd like you to pay attention to your speed and the radio dial. Ready? Here we go. What speed are you going when you hit 97? All right. How'd you do there? Well, who'd you run over this time? Wait a minute, Karl, you didn't ask me to do that. I didn't run anybody over. Oh, let's take a look at this again. But now, don't just look at the speed indicator and the radio dial, but look at the entire screen. This again. Oh, somebody coming across the road. Who was it? No, you didn't run over Mickey, did you? Well, unfortunately, perhaps you might have come really close to hitting him. If you didn't see him the first time, don't be surprised. This is a divided attention problem. The divided attention deficit is going to occur when you can't pay attention to your central vision, something within your central 20 degrees, at the same time as seeing something in your peripheral vision. It's everything outside of that. Or alternately, it might very well be in your field of view, but you're paying so much attention to a particular task that it prevents you from attending to anything else. This is referred to as inattentional blindness. And the reason, of course, that we discuss this and describe this is that all intoxicants are going to cause problems with divided attention. That is what intoxicants do. Now, of course, other distractions can also cause these problems. Talking or texting on the cell phone could be just as dangerous. Paying too much attention to the radio or somebody else or something else in the car, or some task other than driving is going to cause a divided attention deficit. This is one of the reasons why young drivers who are getting their learner's permits and probationary permits and such, probationary licenses, why they often may not drive with other people in the vehicles other than a single licensed driver, perhaps, because they've not yet learned how to properly divide their attention and pay attention to the road while also perhaps paying attention to other things. But intoxication causes all of these problems. So now that we've discussed that, let's consider what critics say about the HGN and VGN tests. Some of these come from a couple of published decisions. Kansas Supreme Court in the 1990s published a decision on State v. Witt, a federal decision shortly after that, US v. Horn, also has raised some of these issues and concerns with the HGN test. But keep in mind that both of these decisions rely primarily on non-medical, non-scientific, and non-peer-reviewed publications. First thing to consider is that critics will say that, well, alcohol and drugs merely enhance or exaggerate nystagmus that everyone has naturally. That is not true. That is not the case. Okay? Alcohol and drugs cause nystagmus and cause particular changes in eye movements. The second is that the HGN tests and VGN tests are new and novel. They've not been proven. Well, if nothing else, our study that was published in 2003, looking at different postures, heck, that's almost 20 years ago. And actually, if you go back in the literature, a lot of work was done in the 1950s and 1960s, demonstrating changes in eye movements that occur with intoxication. In 1993, my professional organization, the American Optometric Association, published a resolution recognizing the validity and reliability of the HGN test, with a slight wording change that was readopted in 2011, and with no change that was readopted in 2021, just recently. So there is support for this test, and it is not new and novel. There are those individuals who say that these tests are scientific or medical in nature, and that the evaluator must have an advanced degree of some sort, or that properly trained officers cannot diagnose nystagmus. This is not what officers are doing. And no, they do not need to be medical doctors nor have any other advanced degrees in order to do this. They just need to have the proper training and education to do it. But what these statements suggest to me is that we're saying an officer can't distinguish between nystagmus that is horizontal versus vertical versus rotatory. Of course, you can tell the difference. That an officer can't tell the difference when somebody's looking to the side versus looking straight ahead. Of course, an officer can tell the difference. Or that an officer can't tell when somebody's head is upright versus not being upright, or when an individual is lying down versus standing or seated, that it all looks the same to the officer. Of course, officers can make these distinctions. Another criticism is that the test is, HGN test especially, is very difficult to do because it involves simultaneous movement of the wrist, the elbow, and the shoulder in order to move the stimulus properly. All that takes is some practice, some physical practice, nothing else. It really is not that difficult to do. There is the suggestion that if the test was not conducted in a certain amount of time, 90 seconds, 66 seconds, I've heard numbers all over the place, then the test is invalid. Of course, that is not true either. And I've addressed this in a newsletter article that I did for the Utah prosecutors and the Arizona prosecutors back in 2007. There is the argument that, well, smooth pursuit really only is a maximum of about 30 degrees per second or so. And the research that the critics point to here involves targets that are very small in size, targets that are presented in only a small portion of the visual field, or targets that are presented at a random location and move in an unpredictable manner. Of course, none of this holds true for how an officer conducts the test. Officer uses a large stimulus, such as a finger or pen cap or a pen light, moves over much, if not all, of the visual field, and moves in a very predictable manner. In that case, of course, as we said before, the actual maximum speed of smooth pursuit is well over 100 degrees per second for most individuals. One claim straight out of the Witt decision from Kansas is that drugs rather than alcohol are the cause of the intoxication. So you're suggesting to me that the Kansas Supreme Court would have accepted an affirmative defense of drug intoxication in place of alcohol intoxication. That really does not make sense. There is the suggestion that drugs or alcohol concentrations too low to affect driving can cause observable changes in eye movements. Well, we come back to our initial premise and the first question that I presented to you, and that is, under what condition is an officer going to be doing this testing? Remember, the officer must have reasonable suspicion of impairment. Officers do not do this testing at random, nor on drivers whom they do not suspect of being impaired. There is the consideration that, well, the defendant was only using over-the-counter medication, not a prescription or an illicit drug. I'm sorry, there are a lot of over-the-counter medications that can cause impairment, and it is clearly identified on their labeling. If you take an over-the-counter sleep aid, what is it intended to do? It's going to put you to sleep. You should not be driving. And of course, certain cough medications, for example, and other medications can have these effects. Now, what about cannabis? That's a whole nother issue, of course, but there is no good evidence yet that cannabis can cause nystagmus of any kind. It can cause lack of smooth pursuit, so that would only be the first part of the HGN, the very first subtest, but there's no evidence that cannabis by itself can cause nystagmus in a way that would be confused for alcohol or other drugs. One of the other arguments from the Witt court is that there are certain drugs that can cause nystagmus that don't necessarily cause impairment. And of course, they list specifically aspirin, caffeine, and nicotine. Once again, it comes back to, yes, these drugs can cause nystagmus, but certain types that would look very different or occur under test conditions very different than how an officer does the testing. But it always comes back to, why does the officer suspect that the individual is impaired? The officer must be able to articulate that reasonable suspicion. There is the concern that congenital or medical conditions can cause nystagmus that will be mistaken for intoxication. There are problems with eye movements. There are problems with eye conditions, such as abnormal growth on the eye, or perhaps redness of the eye, or anything else. Or somebody had refractive surgery, laser eye surgery, or glaucoma, and that is one of the other conditions specifically called out by the Witt court. None of these are known to be associated with nystagmus, nor the onset of nystagmus. So these are not conditions that would cause nystagmus, and certainly not in a way that would be mistaken for intoxication. We'll show you one more video of an individual with albinism. Now, albinism is known to have nystagmus associated with it, as you see in the video here. But you can see that he's got resting nystagmus, and also the nystagmus changes as he's looking at different locations. None of this, of course, is consistent with what intoxication would cause. Now, what about environmental conditions? What is something going on at roadside, perhaps? Is the individual tired? Well, there is something known as fatigue nystagmus. Fatigue nystagmus has nothing to do with sleep deprivation. It requires holding the eyes out at maximum deviation for at least 30 seconds, and for most individuals, closer to 60 or 90 seconds, and then nystagmus will kick in. But that is not consistent with how an officer does the testing, and of course, it has nothing to do with sleep deprivation. Other environmental conditions following rotation, or caloric nystagmus, putting warm stimulus down one ear and cold down the other, absolutely inconsistent with how an officer would do the testing or what we'd expect to be seen at roadside. Optokinetic nystagmus involves objects that are moving in someone's visual field. So the argument made here is that something was moving behind the officer that caused the nystagmus that the officer observed. And we're going to see this in the video. My colleague, Dr. Bob Bertoli, is looking at a rotating drum with stripes on it, and you can see the nystagmus that is present as he's looking at the stripes. But if he were not looking at the stripes, or if he were looking somewhere else other than the stripes, the nystagmus would not be present. With that, the overall conclusion that we have is that the HGN and VGN tests, as well as the other field sobriety tests, are screening tests of divided attention ability. They correlate to impairment, such as that caused by intoxication. They do not, and they're not intended to prove intoxication. Many conditions other than intoxication can cause nystagmus, but almost none cause the same overall pattern of abnormal eye movements that are expected and observed with intoxication. Officers are taught to look for specific types of responses under specific test conditions. And if the response or the test condition is inconsistent with their training, they will not conclude impairment. Thank you so much for your time today. I look forward to answering any questions that you might have.
Great. Thank you so much, Dr. Citek. So we're going to go ahead and turn this back over to you so you can start looking at the Q&A. And so if you do have questions, we do encourage you to put that into the Q&A and not the chat. Also, a quick reminder that these presentations will be available to view later with your login information in about 24 to 48 hours. And I do believe that they're available up to 1 year after today, as long as you have your login information. Most of the recording or most of the presentations that you see today will have a recording, with the exception of Jermaine Galloway's session in breakout session 2. But without further ado, I'll turn it over to Dr. Citek.
Great. Thank you, Cody. Trust you can hear me. Getting a couple of questions in. I do have some updated information on that. I think we just heard that the on-demand videos are going to be available for 30 days. I think that's the, if I'm not mistaken. I've already answered some of the questions in the chat. Yeah, there is so certainly you have access to the video for 30 days. If you would like it beyond that, I would prefer to be able to provide that to you to view, but not to distribute. So, and you can send me an email, and then my contact information is there, and we can discuss that later. Thank you all for the kind comments. Very much appreciate that. I don't see any other questions yet. Yeah, there were a lot of things, obviously, that I could not get into, that I did not have time to. I'm amazed I even got this much in the 45 minutes, but appreciate your time today. And certainly discuss some of those later, or if you have something come up, please send me an email. That's if you think about it later, or something else arises. So let's see what we have in the Q&A. Okay. There's a question about simulating HGN in a school class. You can certainly create nystagmus. So spinning somebody in a chair, rotating chair, that would cause a rotational and then a post-rotational nystagmus. You can create nystagmus that way easily in virtually anyone, but it's not HGN. So just be clear on that. We can certainly cause nystagmus that way, and that would be expected to stick around for 15, 20 seconds after somebody stops spinning. There was another question that I saw. Okay, another question now. When HGN is present, does the peripheral vision become blurry, or is it almost non-existent? So when acquired nystagmus kicks in, certainly your central vision is going to be affected, because, and one of the things I neglected to say in the video is that one phase of the movement of nystagmus is essentially like a saccade. So part of your vision is suppressed during the movement, and your central vision, central vision is then going to be affected. So that's why acquired nystagmus reduces vision. That's what we say, it reduces visual acuity. It would have even a worse effect on your peripheral vision. And that'd be really hard to measure. But certainly central vision is affected, and peripheral vision would be affected as well. So, so there's a question about cannabis. Wonder if there's a glaucoma connection to no HGN. Well, we do know that cannabis, at least delta-9 THC, can reduce eye pressure, and it has been incorrectly touted by the medical community as a cure for glaucoma, to treat the symptoms. Certainly, Delta 9 THC can reduce eye pressure. For somebody who has glaucoma, can reduce eye pressure in anyone, but it's the Delta 9 component of THC that causes that, which means somebody would have to be under the influence all the time in order to have a long-term effect. Beyond that, now, the WIT court in Kansas specifically included glaucoma as one of the things that causes nystagmus that could be mistaken for intoxication. There is no credible evidence to that. And if we have time later, perhaps offline, you can send me a note and I'll give you some information about where the WIT court got that incorrect information from. So let's just see. Okay, there's a question about HGN and high potency THC. There are ongoing studies right now that are looking at that. All the evidence that I have, everything that I know, is that THC, while THC can cause lack of smooth pursuit, there is no credible evidence that it can cause nystagmus in a way that would be confused with or mistaken for alcohol or depressant drugs. It can cause changes in eye movements, but not in a way that we would expect as a consistent signs consistent with the HGN test. So let's see what else. Anything? Okay, can you explain how target fixation is adversely affected by someone with nystagmus, especially in a dynamic driving environment? Absolutely. The issue with nystagmus is that when it is acquired due to intoxication, it occurs when you look away from straight ahead. So when you're looking straight ahead, you're typically not going to have resting nystagmus. Perhaps the only real exception to that is PCP, but alcohol and other depressant drugs and inhalants and other dissociative anesthetics would not be expected to cause resting nystagmus, but they will cause nystagmus when somebody's looking off to the side. And what will happen is we lose the ability to maintain fixation looking off to the side. The eyes want to come back to straight ahead, and then they'll bounce back in the direction in which we're looking. So the direction of the nystagmus consistently changes when we're looking with the direction that we're looking in. So looking to the right, it would be a rightward beating nystagmus. Looking to the left, it would be a leftward beating nystagmus. Looking up with VGN, it would be an upward beating nystagmus. So that is a consistent change. And the fact that the eyes drift off the target by a little bit and then bounce back quickly, that quick bounce back of the nystagmus is essentially a saccade. And that's where, with acquired nystagmus, the loss of vision comes in. Head injuries. Okay, I think we have time for maybe just a couple more. There's a question about head injuries causing nystagmus. The only type of head injury that can potentially cause nystagmus in a way that is consistent with what intoxication causes is if the cerebellum is damaged. And the only way that can happen is with a violent whiplash type injury, where the head is violently moved forward and back with respect to the spine. And essentially, that is a type of injury that no longer occurs, that cannot occur anymore, because since 1972, all vehicles have either headrests or extended seats to specifically prevent that kind of injury. So that is not a type of injury that we're going to see. Any other type of head injury, blunt force trauma, even gunshot wounds, bomb blasts, and these have all been investigated and it's available in the literature, rarely cause nystagmus. And if they do, it's not going to be consistent with what intoxication causes. Let's see. Okay. Mr. Mohammed, thank you very much. We'll see what we can do about getting the information for you for viewing, and for anyone else, of course, as well. So send me a message, send me an email separately afterwards. All right. I think, Cody, I think that all the Q&A questions.
I believe so.
I think so. All right. I mean, you have my contact information there, and email is the best way to get a hold of me. Well, thanks for having me here today.
All right. And thanks again, Dr. Citek. So we will be sending out an email post the conference that will have information on how to access all the different videos and items that you'll see today, as well as it should have a website to go to that'll have contact information as shared by our presenters today. So, but we're going to go ahead, and it looks like no more questions. So we're going to go ahead and close this one down, and we'll see you guys around 11 o'clock for our breakout session 2. Thanks again, Dr. Citek.
Great. Thank you very much. Have a good rest of the day, rest of the conference.